Hi, I'm Chris Sanborn, and I'm honored to be asked to present for the Erlanger Symposium. And our topic today is going to be a pocket guide to metabolic and bariatric surgery. Want to kind of go through a little bit about obesity and then the management of the obesity, and then some of the things you may encounter when you see some of our patients in your clinic, or even some of our prospective patients in your clinic. As far as conflicts go, I don't have any conflicts to report. I always like this quote, for every complex problem, there's a solution that is simple, neat, and wrong. And I think that if you look back through our treatment with obesity and everything, and the more we try to find some of these just simple things without attacking all the other aspects of obesity, I think the struggle with that just makes this quotation that much more correct. So if we have to define obesity, we define it now as a disease. And the Obesity Society here gives pretty extensive definition of obesity. But in short, it's more of a disordered energy balance with the formation of excess fat and the complications that come along with that. So if we talk about some general definitions with obesity, we can see that the BMI, or body mass index, is calculated as the kilograms of weight over the height in meters squared, and that gives us some numbers that we can compare populations of patients. And we can see here that our normal weight individuals are typically between 19 and 25. Overweight begins after 25, and then obesity after 30. We also have class 2 obesity, class 3 obesity, as you see here. And typically when we're talking about surgical patients, we'll talk about class 2 and class 3 obesity being BMI 35 and up. You can see here from the distribution of weight in the United States, have kind of gone beyond showing maps of the United States, because I kind of feel like we unduly pick on certain states sometimes that way. But if we look, and this is just a nationwide problem, and quite honestly, if you look at the rest of the world, you're going to see something that looks very much like this in each of the industrialized countries anyways. And you can see here that the normal weight individuals, those people between BMI of 19 and 25, are only about 30% of our population. So that leaves the rest as being either overweight or obese. And then even our severely obese, being BMI of 35 and above, is a full 10% of our population now. So just from looking at that distribution, that makes this quotation seem to come into play a little bit. And of course, we know Pericles was actually talking about obesity, right? Because just because you do not take an interest in obesity doesn't mean that obesity won't take an interest in you. This is going to be every time we've done something for bariatric patients at Erlanger or anywhere else I've been. One of the arguments I've always made is that this is going to apply to more people than they're in our program, because everybody sees people who are overweight and obese. With numbers like I just showed you, it's going to be hard to avoid that. So one of the things always comes up with is, maybe there's some obesity is merely disease of lifestyle issues. Maybe it's a choice or poor eating habits and lack of exercise. And certainly there are things that those have a role in the development of the disease, more so now that we know there's a lot of genetics and hormones and a lot of different imbalances within the physiology that are involved. But let's just take this on face value. If we thought this was the case, then it's in good company, right? Because we look at other lifestyle diseases in the United States, and we see a lot here that we treat every day: hypertension, heart disease, lung disease, diabetes, high cholesterol, arthritis, overweight, all those things that do have some relation to obesity as well, but are also considered lifestyle diseases. And I really haven't even gotten to sports and trauma. And certainly you can make a case for those being lifestyle diseases as well. And certainly we treat those with some veracity that maybe we don't all the time with obesity. So it's always something to think about. And if we kind of take away some of that stigma of this just being a lifestyle or a choice and those kind of things, and we treat it like any of these other diseases, becomes a lot easier. And of course, I won't go through the laundry list, and this is actually just a partial list, but we know that obesity affects a lot of other organ systems. In fact, if you look throughout the symposium today, it'd be hard to find one of the talks that doesn't have something to do with obesity somewhere in the root causes of the problem, or things that are exacerbated by the problem. All-cause mortality goes up as body mass index goes up, and this has been used for decades to impress upon people that obesity is a disease, and that it actually increases the risk of death in and of itself. And that's what we see here, that as we get to a BMI of 35, we about double the risk of death. And as we get up to about 40 to 45, we start tripling the risk of death. Now, one thing I'll even mention to patients who see graphs like this is that the risk of death is actually a pretty small number, but the magnitude of the increase is kind of the important point of this. And that's due to the body mass index alone. Other causes of death have been separated out in that analysis. And of course, we also know obesity has effects on the individual. Just a lot more depression, anxiety, self-esteem issues. Those patients with obesity tend to achieve a lower educational level. They have lower employment status, lower salaries. They are less likely to marry, but actually more likely to divorce as well. And there's a higher suicide rate. Now, we talked just a little bit earlier, and I alluded to some of the causes of obesity. When we talk about metabolism, I'm not going to go through all the different hormones on here in the short time that we have available to us today. But if you just kind of glance at this and know that this is a very watered down view of a schematic of some of the mechanisms of obesity, then we know it's a very complex problem hormonally. And a lot of this boils down to kind of a set point theory for fat storage, in that the body has a set point, almost like a thermostat, that tries to keep the weight within a certain range. And as you see from here, that we can look at this graph here, you can see as you would increase the energy intake, then the energy expenditure in a compensatory manner goes down, and that will actually help to keep the weight at the same sub spot right here. And that's called metabolic adaptation. Now, there's other things that we can do to affect this curve, and that sets up what I usually call kind of the battle for set point. And you can see here that we have a set point there, and there's a lot of things that affect that. And these are all the things we talk about affecting obesity a lot. And one is altered food supply, stress, medications, unhealthy muscle, impaired circadian rhythms. All those things tend to push that set point to unhealthy weight balance. Now, there's some voluntary control that we can exert over that, but that's very limited. And then we can add treatment to that voluntary control, and then hopefully we can push that set point to a healthier area. This slide right here is just to show you there's actually variation in response to diet. So the disease of obesity is very heterogeneous. It's different within different individuals, and therefore we shouldn't expect everybody to do the same with any individual treatment or diet. And that's what you can see here is this diets have been changed, and we're getting different responses based on the diets. And in this graph here, I love taking a look at these right here, because what we're looking at here is a difference in one gene and one base pairing of the gene, and we see a difference in response to changes in the diet between the individuals with those different base pairs. And that's all one base pair that's changed in one gene is associated with that. So we can imagine all the different genes that are associated with obesity and the management of energy balance, and changing any one of those is going to change that. And of course, we know that's going to be different in different individuals. And again, the same thing with response to therapy. And certainly we see that diet, we can get a certain response with a certain diet, and same thing with a drug. And of course, we're looking for those with the best response, but that's going to vary on the individual. So again, we can't expect any given individual to go through a treatment and have the same results that everybody else would. Okay, we can make some generalizations sometimes, but we certainly don't have one single treatment or one single diet that tends to be the best. And this is just to kind of reemphasize that this is zones of lifestyle opportunity. I adapted this from a much bigger similar picture from Dr. Kaplan. He gave a great lecture on this. And this is just showing individuals. And you can see this individual here keeps their BMI within a certain range. And that's pretty much as much as they want to try to eat, or as much as they try to starve themselves, they're going to keep themselves within this range. Another individual, because they're genetically different, is going to be able to do that over a much wider range. And so again, that's why we see this polymorphism in the differential response to diets and treatments. So taking all that together, we kind of really come up with the approach now that the physiology of energy balance guides the behavior rather than the behavior driving the physiologic energy balance. And so it's kind of a different way of kind of saying what you're seeing is the expression of that physiology when we're looking at obesity. And we see the end results, we see the mechanisms to support that disease process that are being driven by the physiology. It just happens to be that in most people that are overweight or obese, that physiology has been deranged to the point that it's unhealthy. So just a second to take a little bit of realism and look back at what we've talked about here is that there is no 100% treatment. Nothing's going to work for everybody because everybody's got a different form of obesity pretty much. And diet and exercise aren't enough to take care of all that. Most medical therapy is going to have modest results and take time. And that's why we'll talk a little bit about surgery. And then it's likely that most patients are going to require multiple modalities. They may need medications, they may need surgery, then followed by medications. And certainly with all that, we're going to work on diet and lifestyle changes as well. And one thing that we should know about this, as much as obviously as a surgeon, I like to operate to help this, and it's a very successful technique, we can't operate ourselves out of this problem. There's not enough surgeons in the world that can do this surgery that take care of this problem for as many people that have the problem. So we have to come up with other solutions. And right now, a lot of that's probably going to be around prevention of keeping people getting into the problem in the first place. So we'll start talking about the metabolic and bariatric surgery, mechanisms of action. These typically revolve around restriction, malabsorption, altering the gut hormone response to a meal, neural mechanisms such as vagal response, gut microbiota changes, altered thermogenesis and energy expenditure changes, and also increasing the circulating bile acids have been associated with weight loss as well. And we can see here the major surgeries that are still offered here, and this would comprise most of them. I will say that the gastric band over here is not commonly done in the United States very often. It would be less than 2% of surgeries in the United States. You know, at one time, probably 15 years ago or so, this was one of the predominant methods of weight control in regard to surgery. And because of some problems with these long-term, we're not seeing that one used as much anymore. So here, what I usually do is either a gastric sleeve or gastric bypass, but duodenal switches are being done as well. And just a note about duodenal switch, and this is another one is done only a few percent in the United States. And that's because it's probably the most malabsorptive operation we have. And there tends to be a little bit more nutritional risk with that one compared to our others. Now, mainly what we'll see around here is gastric sleeves and gastric bypass, but you will see an occasional duodenal switch that's been done elsewhere and that we see in our Chattanooga area. The other thing I should mention, because you'll see a little bit about there, these are done with two connections. When we bypass the bowel here, we have a connection from the stomach to the bowel, the gastrojejunostomy, and then from bowel to bowel here, jejunojejunostomy, and a similar setup here, even with the switch. It's just a much longer bypass there, and we've actually preserved the pylorus in that one. But these are both done with a single anastomosis by bringing things up as a loop as well. We're still trying to figure out if there's an advantage to having a loop versus dividing these. And when you account for the length of bowel bypass in those, between a single and a double anastomosis type bypass or switch, the results are probably going to be fairly similar. So that's one thing, you'll see a little bit more of those out there. We do see a little bit less of the sleeve being done as a trend, and that's having to do with reflux issues with the sleeve. And so that's driving people to a little bit different operation, or sometimes even changing from the sleeve to a bypass or even a switch for reflux issues. Now, we talked a little bit about the mechanisms a second ago, but just to show you the common trends in the mechanisms here, if I get my cursor back there. We do something that seems to create some restriction, a smaller stomach in the case of a sleeve or a switch by doing the sleeve resection. And then in the case of the gastric bypass, we have a small gastric pouch. I tend to not think of these as pouches or having holding capacity, in that they usually spirit food directly into the small bowel. That accelerated entry into the small bowel and accelerated transit through the small bowel tends to give us those hormonal approaches to weight loss. So we get those changes in the PYY, the GLP-1 that we see. In the sleeve and in the switch, and even to some extent in the bypass, we've talked about ghrelin being decreased, but that's still something that's kind of one of those putative factors that hasn't been well proven that that's actually the factor responsible for the weight loss. The surgeries that we are looking at here are all done laparoscopically, and you can see here a series of small incisions compared to one big incision in the open surgery, and that's something that's been a big difference in the last 20 years is this move towards the laparoscopic surgery. Obviously, laparoscopic surgery patients get out of the hospital a little quicker, they have less pain, they're able to move quicker, and we've seen less complications as a result of that. Here we use the robot quite often to help us with that, get a little bit finer movements and everything. But overall, the outcomes that we've seen have been fairly equivalent between the robot and doing things without the robot, just with laparoscopic without the robot assistance. And so that's been pretty much the same outcomes, but a little bit easier to do on the robot, and certainly some ergonomics that are much better for the surgeon and patient as well. And we can look at these procedures and the effectiveness of them. This is just to show you a little bit longer term outcomes here. And this is out 10 years. And we can see kind of the typical weight loss curve. And that we take these patients right here at the gastric bypass, and you can see they lose weight, and they lose that over the first year or two. There's a little bit of a regain, and they sort of level off over time. And you see a very good persistent weight loss here, even over 10 years in the Swedish obesity subjects trial. And then we can see back here, we saw some kind of similar curve with the gastric banding, though much less. And then we actually see lifestyle and medications up here. So not as effective and not much overall weight loss there on average. So if we kind of want to look for trends, one of the trends is, yes, as we get more invasive, we tend to get a little bit better response. And we have here anywhere from diet and exercise down here is not much invasiveness there to using pharmacotherapy, things like balloons and everything. Of course, there's the band down there, which didn't do much better than some of these other methods. And then we get to the more common surgeries that we usually talk about, the sleeve, the bypass, and the switch up here. And you'll notice as you're getting up here, this curve starts leveling off. So the invasiveness, there's a tendency for a lot of people to look at these and try to define those as a differences in invasiveness between them, but they're very close together. And I'll show you in a minute how close they are. And again, even though we talk about surgery, we don't forget about the pharmacotherapy and the lifestyle modifications. And the arrows here to show us that we don't just, it's not just escalating, we forget about these other tiers. We go back and forth, to the different, tiers to get the best effects. So who do we operate on? In general, these come from still the NIH criteria that were given out basically about in 1990, and they've been around without much change since that time. BMI of greater than 40 alone typically would qualify for surgery, and BMI 35 to 39 with comorbidities. Now, some insurances specify which comorbidities, but typically if it's 35 and above, you may have a hard time finding somebody without comorbidities that can be identified. Now, BMI 30 to 34.9 or under 35 with inadequately controlled diabetes is an indication for surgery at this time as well. Surgery for diabetes under BMI of 30 is investigational and is not wholly endorsed yet. Not yet anyway. So adjusted BMI criteria for ethnicity, you have to look at this in case in point would be Asians who end up being a little bit more sarcopenic. Therefore, we see consequences of overweight or obesity at lower numbers. And you can see here the BMI of greater than 25 and somebody, let's say from Korea, may be considered obesity. And you will see higher rates of diabetes starting at lower BMI in those patients as well. As an aside, when you look at age, as age goes up, BMI may falsely give an impression that the degree of obesity is a little higher in those. And the reason why is because we lose some height as we age. What that'll do, that'll throw the calculation off a little bit and make our BMI falsely a little bit elevated. So other criteria, got to be able to participate in follow-up. They have to be acceptable operative risks, of course. Be able to understand the risks. We want the patients to be well educated about these things, know their long-term commitments and the need for the lifestyle changes, because if they can't make those changes, the surgery is probably not going to be that successful. Be up to date with age-appropriate cancer screening. We maximize diabetes control preoperatively, ideally be a hemoglobin A1C less than 8. Sometimes we end up we have to operate to get the diabetes control in some patients, so it can be difficult. No smoking, that affects the leak rate and ulcer rate afterwards to a pretty big degree. And then no active substance abuse or psychological conditions. Not that they couldn't have ever had a problem, just can't be an active issue. Some challenges. Again, smokers are a challenge because we want them to quit. And unfortunately, we don't always get the permanent quit. And let's say we have somebody had a bypass, needs to quit smoking and get their surgery. They may quit and then they may get their surgery and go back to smoking, and then they're going to be an ulcer risk. So it can be a little bit of an issue. Patients with specific medication requirements, transplant patients, whether it's pre or post-op, we have to consider those things. Advanced age, how old is too old for surgery? That's kind of a hard call sometimes. I think the oldest that I've operated on has been 79. Her parents both lived over 100. So we figured she had some time to enjoy the benefits of the surgery, and she has. Advanced medical illnesses, sometimes the associated medical illnesses are so bad that the surgery risk may be prohibitive, and there may be such a thing as end-stage obesity. And then one of the other things that everybody talks about a whole lot is the risk stratification that goes on, and looking at outcomes databases is not quite strong enough to overcome risk aversion, meaning that a lot of centers are dependent on accreditation with national governing bodies and, of course, insurers. And not to jeopardize that, they may avoid higher risk patients. So those who may need the most help may not get the help because of things like that. Some of the things that go into choosing a procedure, and I'm going to kind of limit this to just a couple procedures at this time because these are our local practice here. Diabetes typically does better with a gastric bypass. Reflux definitely does better with a gastric bypass. Our patients who cannot give up their NSAIDs or need their NSAIDs are probably going to be better with a gastric sleeve. By the book, NSAIDs and steroids are contraindicated in both operations. In practice, a lot of patients have been able to tolerate NSAIDs with gastric sleeve. I've always cautioned those patients, though, not to count on that because, as you know, there's a lot of patients who have never had surgery. We find some reason, whether there's ulcers or other problems, that they cannot take their NSAIDs. So NSAID use wouldn't be guaranteed in them either. Higher BMI is kind of a maybe, maybe not, but because the weight loss tends to be a little bit more with a bypass, a lot of people will gravitate towards a bypass for a higher BMI patient. And then a smoker, and this is always an interesting one here, smoker has to quit anyways for either procedure, but if they've quit, we know the high recidivism with smoking. And so sometimes we think about a sleeve because if they go back to smoking afterwards, maybe the ulcer risk isn't as high, although we have to consider that they may have reflux, one of the common problems with the sleeve. And if it was bad enough we couldn't control it, maybe they have to be converted to a bypass to fix that. And then it kind of gets you into a little bit of a position you don't want to be in. So for us, we have smokers quit for 3 months. It doesn't guarantee anything, but hopefully it means they're a little bit more committed to it, that we might get a permanent quit for that. We use some other tools. This actually comes from a calculator. It's published by Dr. Armenian, and it's pretty good. You put in some data about the patient here, how long they're diabetic, how many meds they're on, whether they're on insulin, and their level of glycemic control, and we can calculate scores on how severe it is, and then we can recommend which surgery might be better. The one big flaw that I had seen with this calculator and addressed with Dr. Armenian that they didn't look at in that was this is based on trying to get the patient resolved or in remission with diabetes. And so if you get so severe here that both operations may only be 10% to get remission, this will suggest a sleeve. Now, your best chance to get them off the insulin is probably going to be the gastric bypass. And of course, if you've treated diabetes before, you know getting off the insulin is a big deal, especially when it comes to weight as well. And so if we take an endpoint of looking at getting them off insulin at least, then a bypass is still going to be better even for the severe. So there's always some caveats on these as well, but it's a pretty useful tool and also makes it a little easier to talk to the patient about these things. If we look at the morbidity, the risks of the common surgeries, you look at bariatric surgery and it falls right in line with a lot of other surgeries here. Okay, I'm not sure if CABG is still in this day and age or still at 15%, but the rest of the numbers hold true here that the bariatric surgery is really not any more morbid overall in terms of surgical complications than a laparoscopic gallbladder or even a hysterectomy. And then mortality of common surgeries, it fits in right there very well as well. Overall, about 0.1 to 0.3% mortality. And this is something else you can go to riskcalculator.facs.org. And I've taken here and tried to get us just maybe an average patient that we could take a look at here. This patient is 65 inches, they're 280 pounds, and they gave them a BMI of about 47 there. They're a female, they're 43 years old. This one here is non-insulin dependent diabetes, and they have sleep apnea, hyperlipidemia, GERD, and hypertension. And that seems to be a pretty average patient for us. And so what we can do with this calculator, we can take a look at their 30-day risk. And if we look at their 30-day risk, you can look down here, and that risk of death, that risk of death is really not that much difference between them. Now we look at risk of complications and we see a little bit of difference, and we take our middle two here, which is going to be our sleeve and our bypass here. And you can see there is a difference there, but we're still less than 10% on any complication. And then as we go here, we're less than 5% on any complication between those two. So, you know, when you get right down to it, the risks are actually pretty low. I mean, they're real risks, but they're low. Look at risk of leak. And it's been said before, and a lot of advertising for people like to do sleeves and everything too, that the risk of a sleeve leaking is about a third of the risk of a bypass, or the implication is 3 times a risk leak with a bypass than it is a sleeve. And that's fine, but the risk leak with a sleeve is about 0.1%. And if you triple that, it's about 0.3%. So pretty low either way you go. And we kind of see that across the board here, even reoperations, readmissions, and any kind of intervention at all. So this makes a good tool to go through with the patient. They can also compare on something like this, and we can take a look at the weight loss at a year. Okay, and again, we see a duodenal switch down here. And again, you say, boy, this is the most effective one, but the nutritional issues from that one kind of causes some hesitation from some of us on wanting to employ that one. Gastric bypass right here, the sleeve, and then of course the bands up here. And then we can take this and we can even look at the 1-year comorbidity remission. Okay, we can go over here and we can actually see here total diabetes and remission. Okay, we know even higher percentage of these are going to be improved off their insulin, better control on just oral medications. So this gives us a great tool to be able to go through this. And this is certainly something you can go through as well. You will have to prove you're not a robot, but otherwise you should be able to sign in and do it. So ultimately, this comes down to risk versus benefits versus risk decision. Benefits of surgery versus risk of surgery, and then also we have to look at the risk of remaining morbidly obese. And as you can tell by this person, there's a little perplexed here in the middle. It's not always the easiest thing to do because we're trying to predict the future. That's a very difficult thing to do. Pre-operative pathway that we use here usually starts with they prep for the appointment. We ask them to watch a webinar or seminar so they're educated already with a baseline of information before they come in. History and physical, the nutritional evaluation, education, psychological evaluations, labs, usually an upper GI or EGD, and then additional evaluations, and then some records that we need to look at as well to see how long they've had problems with obesity and what's been done before, and make sure that they have failed non-operative management. So we do the surgery and then early post-operatively to get an idea of some of the things that we do with them. They're in the hospital a day or two. Thromboprophylaxis is a big deal. A lot of people are getting Lovenox. Some go home on extended Lovenox. And there's a diet progression from liquids to puree to solids that happens over about 4 to 6 weeks. And you can see here we have a 60-60-60 plan that's pretty much 60 grams of protein, 60 ounces of fluids, preventing dehydration, and then 60 grams of carbohydrates to help prevent ketosis in the early period, because in the early period, it doesn't seem to be as tolerated as well as it is later on. No more than 15 grams of carbohydrates in a meal to avoid dumping, and that can go with sleeves and bypasses. Both of them can experience that. We want to keep the patient moving, up and walking, and then usually back to work in about a week or two, maybe a little longer if they have lifting involved. And you can see here post-operatively, we see them very frequently, and we check their labs every 6 months. We make sure that they're exercising, and we also try to make sure they include resistance exercises, as building healthy muscle helps with guiding healthy weight long term. Intermittent dietitian visits are needed to make sure those dietary changes are permanent. We have behavioral therapy support and support groups as well. Some post-operative things that you can see when they come in, if they're not tolerating things very well, they may have ketosis. And again, early on, that's not such a good thing. They don't tolerate it well. Later on, ketosis may not be such a bad thing for them in terms of weight loss. Nausea and vomiting, you may see that from an ulcer or a stricture. A lot of times that may be diet compliance induced. We see abdominal pain, and we have to think about, again, ulcers or strictures, sometimes constipation. Gallstones are fairly common afterwards, about a third of patients, and then potential internal hernias and bowel obstruction, and then the other usual causes of abdominal pain in anybody else that hasn't had surgery. Dumping symptoms we can see in either our sleeve or bypass surgeries. Postprandial hypoglycemia can be seen and usually is managed just with dietary modification. Again, constipation, gas, hair loss. Hair loss typically goes along with the weight loss and typically comes back after the weight loss has plateaued. It's one of those things I get asked about a lot, and I always tell our patients that I have had patients lose some hair and get fairly thin, but never had any of them ask to get the weight back. And the same actually goes for excess skin as well. Weight regain, it's not commonly a surgical issue, but we do see the issue. It's just usually comes down to more of the diet and exercise patterns. We do track vitamin supplements pretty closely afterwards here, and you can see our typical mix of what we use, and we check for these periodically with our labs as well. Medications after surgery, some considerations. They don't need a split, crush, or change their tablets to liquid form. Usually they can tolerate pills as well. That anastomosis is about that big around when we start off with it, and anything bigger than that usually turns on in to go through. May have to titrate the dose to effect. There's some differences in bioavailability, and then some of the newer drugs may not have been tested specifically with bariatric patients, so you have to be particularly careful with those. Proton pump inhibitors, just assume there's some altered bioavailability. You may have to give them in higher doses. We use them for about 3 to 6 months after surgery just to prevent ulcers, and then after that, we go back to usual indications for those medications. Extended release medications, again, have to be careful with those. We don't want patients splitting or chewing those and getting all that medication right at once. And we also may have to change dosages of those to keep up with good effects. Low pressor is a good example, and that's one that we usually switch to immediate release form. Usually requires some gastric acid for breakdown, and also usually requires to be taken with food for best absorption. NSAIDs and steroids are a big one that's contraindicated in bariatric surgery because of risk of ulceration and life-threatening bleeding. It's always a risk-benefit question when deciding to use it or not, and it's commonly given the gastric sleeve patients without too much hesitation. But if you're going to use it in gastric bypass patients, you want to make sure that you're using the lowest possible dose, and then you want to use ulcer prophylaxis medications. That's PPIs, H2 blockers, sucralfate, and even going back to one of the older drugs, misoprostol, tends to give some protection as well. The direct-acting oral anticoagulants, the DOACs, They have been used in bariatric patients, but they haven't been really well studied. So you have to be careful with those. In general, if it really matters, you probably should use a drug that you can accurately manage with monitoring levels, such as vitamin K antagonists, warfarin, and such. Diabetes de-escalation does deserve some special mention because afterwards their insulin requirement will not be as much. They're not taking as much carbohydrates, so we have to be careful with insulin afterwards. So we typically avoid long-acting insulins. We avoid things like metformin due to possible dehydration after surgery, and the gliflozins because of potential for ketoacidosis in those patients as well. Emphasis is going to be on avoiding hypoglycemia, so we tolerate higher glucose levels after surgery. If you see an inpatient with a history of bariatric surgery, no blindly placed nasogastric tubes. Use fluoroscopy to place those. They're rarely used after bariatric surgery, so it's usually not a problem. Give thiamine early and often. These people deplete their thiamine very quickly, and the complications from a Wernicke's can be very severe. So make it a standard order, and if there's any suspicion at all, start with high-dose therapy and don't wait for a level to come back. The other things are, again, NSAIDs and steroids are typically contraindicated. We want to treat dehydration and break their ketosis if possible by adding dextrose to your fluids. Respect the diet. They come in that they may have been on their diet and doing well with it, and they're going to be pretty upset if they get put on a regular diet. And some other patients may not be. So talking about what they're eating, so that will avoid some conflicts. And remember that bariatric surgery is just a portion of their history. And so finally, just some parting words on things that we talked about here today. Obesity is a disease. You're going to see it. Make medications and interventions part of your armamentarium. Please have something for your patients or know where to refer them to. Set realistic goals with them and set a realistic timetable because often, and especially if you're doing something other than surgery, you're not going to get very fast weight loss and not that much depth of the weight loss very quickly. So they need to know that. Interventions are most effective when they're employed early in the course of the disease. And again, all through here, we've talked about things. And no, I didn't talk about diet and exercise that much. They are important. They're part of everything we do. They're just not enough in and of themselves. Okay, I appreciate you tuning in for the presentation, and I'll be available in the panel for any questions. Thank you very much. Good afternoon. This is Chris Sanborn again, and I'd like to answer any of your questions. Thanks for sitting through my lecture today. I went a few minutes over, but they still give us a few minutes to work with here. First question I have is, are there any requirements? Do we recommend patients to attend physical therapy before or after surgery, especially those with joint pains and weakness? And we do believe in prehab programs and everything. And for some of our patients, if mobility is a big issue for them, we try to work on that. It is an area that we have to work on carefully because when we send patients to physical therapy, they may have only so many physical therapy visits kind of in the bank, so to speak, with their insurer. And they're also undergoing joint replacements and things like that. So we have to be careful not to deplete all those. Now, beforehand, it's pretty good because you can require those, but afterwards, it's difficult to have teeth because you've already operated on them. So, we do try to get them to engage, but as far as requirements afterwards, it's a little bit more difficult. One of the other questions we have here is, what do we recommend for people who have psychological issues that cause them to overeat, whether that's boredom or comfort eating, stress eating, et cetera. And I think that's a big issue. And we do a psychological evaluation on every one of the patients that we operate on. And part of it is to predict some of these problems and identify these problems and work on it. And then we work with counselors to help them with changing behaviors and everything and coping with those things. And it's a big deal trying to find things that are impediments for them, such as comfort eating and things like that. And I warn the patients about that as well. As one of the reasons we want to find those things is because afterwards, we're going to put a big dent in their ability to comfort eat. And they're going to have to find something else to help them cope with stress or other situations. And we want those to be constructive things and not destructive things. So that is a big focus on the preoperative evaluation as well. let's see, what did we think about some of the discussions of liraglutide for weight loss, such as Saxenda, and there's other applications coming out for these GLP-1 agonists as well. I think they're good. I think they have a mechanism of action that replicates part of the mechanism of action that we see in the gastric bypass and even gastric sleeve to a certain extent. They seem to be pretty effective compared to the other medications. Now, that's still relative, speaking, because effectiveness of medications isn't that big across the board. But with those, they tend to be at the higher end of that, and I really like the mechanism. They're fairly convenient, except for being an injection. They're probably weekly forms of those coming out before long. And some of the biggest limitations tend to be the GI effects from the gastroparesis and the intolerance that comes from that. The question is can we use those at a later period of time to augment what we do with surgery, or do we already have enough of a GLP-1 elevation already that it would be just redundant and wouldn't offer much else? And that's probably going to be seen in studies upcoming. Is there a preferential order for pharmacologic weight loss treatments, and which would be recommended first? There's actually not that much of a preferential order, because some of these patients have tried things before and we're trying to do something a little bit different. One of the last things we want to do is go back to something that didn't work for them before. Some of the easier ones to use are going to be your phentermine medications in various forms, just because they're actually some of the more affordable forms that you can get. And they also are something that's well recognized with patients as something that might work. And of course, long term, that has to be managed pretty well. But then the other forms, it really depends on the patient, individualizing and looking at other diseases they may have, especially the diabetics. You may want to look at your GLP-1 agonists and everything for those, or maximizing what you're doing with other medications, even metformin and the like. But it wouldn't be a specific order, and you can add to those medications. So if one's working and you're not quite getting everything out of it, you can certainly add others to it. So I appreciate all the questions, and I appreciate still having a little bit of time left to answer them. And thank you very much for spending some time with us today. Thank you.